Hello, and a very warm welcome to all the attendees on this very important day when our e-Gurukul series, with the blessings of Dr. P.C. Mahapatra, has completed 1 year. And, this is absolutely a coincidence that today is the Teachers' Day. And Dr. Mahapatra especially insisted that let's keep it on this very day so that we can celebrate this whole day in a very unique way. And Dr. Mahapatra has again given us a very interesting topic for the day, which is the decision making, the decision and dissection in gynecological surgeries, the tips and tricks. So, to make this occasion more memorable, I would request Dr. PC Mahapatro to, please start the session and enlighten us on the topic. Thank you, sir.
Thank you again, Dr. Diwan and the whole team of Juventus. I think I'm so happy that we have completed 1 year of our e-Gurukul series under your academic partnership of Juventus. Well, we started on 5th of September 2020 and looking forward for 6 episodes. Then I'm surprised that now we are in 18th episode today, and the first anniversary we are celebrating on a very auspicious day, the same Teachers' Day from 2020 to 2021. The first anniversary is completed. I don't know whether we will continue this or this is the end of the program, but this is a very good initiative by Juventus, and I personally thank all of you for your personal interest in conducting this e-Gurukul series over 1 year. I'm so grateful to you and to my viewers who have stimulated me to continue the teaching program on and on and on. And that's why I decided that again we will do the first anniversary today on the 5th of September 2021, a very auspicious day. Well, therefore, again, my viewers, my favorable gynecologists, my students, my teachers, my colleagues across the country, I welcome to the first anniversary episode of e-Gurukul. Again, the theme remains constant, the surgical skill transfer and solving clinical dilemmas. Bring greetings from the great Lord. And before going to the subject in particular, on this particular auspicious Teachers' Day, 5th September 2021, I salute to my teachers who have taught me A to Z of gynecology. Frankly speaking, this is a mere submission of mine. What I am today is because of them. It is their blessings, their gift, their teachings, which I'm just transferring to the next generation and to all of you. It's none of my credit and none of my own work for that. At the outset, I must salute this great lady, Professor Sujata Mahanti. And she is an insignia that age is no bar for learning. Till today, at the age of 80s, she is operating, she is seeing patients. I hope, I pray God that let God bless her with all physical and mental faculty. And Professor Radha Mahanti, RCM, her husband, a very reputed orthopedic surgeon and a professor and a teacher for the last so many decades, producing wonders orthopedicians across the country and the globe. I salute you, madam, on this auspicious day. Professor S.N. Das, and he taught me also a gynecology A to Z. When I entered into the postgraduate, I learned what is gynecology from a person like Dr. S.N. Das. And Professor Kanungo, a professor, ex-professor of pharmacology. She's also a teacher of mine. I salute to both of you on this auspicious occasion. Professor S.N. Tripathi, I think she, as far as knowledge is concerned, till today, she is writing books She's going for talks and very actively involved today. And she is one of the insignia of teachers and a mentor of mine in teaching program. Professor D.K. Patnaik. The real, when I joined as a postgraduate, he was the lecturer, and all emergencies, the beginning of the surgeries in gynecology, I learned from him, starting from exoscopy to endoscopy. He is the person who inspired me and pushed me to the field of endoscopy. And believe me, he usually tells that you do this surgery, I will assist you, I'll fund of assisting you doing the endoscopic surgery. He's a great man, Dr. D.K. Patnaik, professor of gynecology. And Professor S.K. Mahapatra and Madam Mahapatra, both are teachers of mine who have given a lot of knowledge and stimulus and enthusiasm in the field of teaching, in the field of surgery, and in the field of gynecology and obstetrics in particular. I bow down my head before all these 5 teachers who are still alive, and I pray God to continue and lengthen their life, and not only lengthen their prolonging their life, but physical and mental ability till the last breath, so that they will be blessing me for all time to come. And that is the desire today. I must salute before starting my own topic, particularly with this, particularly teachers who have taught me A to Z of gynecology. I bow down my head again before starting the program. Well, again, first, I didn't think that we are celebrating the first anniversary. Its time is passing so swift, and within the corona time also we have started, and just we are celebrating today the first anniversary, the e-Gurukul program. And I congratulate the Juventus people, the team Juventus, for their really interest in propagating this program. What I find, everybody in the team, in the head office, are present and actively involved in this Gurukul program. I think I really respect all of you. I really reciprocate with all of them, starting from Mr. P.K. Gua, who is my younger brother, who I love most, starting from the beginning of his career, and all the staffs of Juventus for giving me this platform to all of you, to interact with all of you. And that signifies the interest in teaching, not only promoting the products. All pharma promote products. This is a unique pharma which is promoting education. And that's why I hats off to you and the team Juventus for all this. Now, viewers, ladies and gentlemen, this 18th episode, I have taken a little different ways, not on a particular focusing topic, but it's a very important concern and a hidden thing which nobody realizes. But this is important. This ultimately results in the quality of surgery, and therefore decision and dissection in gynecological surgeries. I will just enumerate few of the tips and tricks, and what are the clinical dilemmas that is arising out of it, I will just point out. Leaving the obstetric decisions, we'll discuss obstetric decisions in a different way because that's a separate arena by itself. But the decision and dissection of gynecological surgeries, which is incorporated day in and day out before the gynecological surgeons in all gynecological surgeries, may it be minor, may it be major, may it be emergency, may it be elective, may it be endoscopic, may it be conventional, whatever it may be. These are the 2 paramount factors responsible to make one person called a surgeon, and that is important. And therefore, this episode, I will just deal with all these 2 different aspects. Believe me, to me, the concept is there are innumerable operators across the globe, innumerable operators, but I find very few surgeons. There's a difference between operators and surgeons. Operators are just, I think, they are all operating just for sake of operation, not for the sake of surgery. And surgery means the quality matters, and the technique matters, the skill matters. And that's why the need of the hour is to convert from operators to surgeons. And all of you must think, must have a willpower to develop their own skill to become surgeons for excellence. And if you think like that, you will achieve. A strong commitment and introspection will make you a really a worthy surgeon ever possible for that. So the need of the hour is surgeons, not operators. And whether the surgeons are gifted or created. People say that they're born surgeons. No, it's not born surgeons. It's a quality which you acquire. We acquire to various sources, and I have already narrated in my first lecture the surgical skill transfer, how this surgeon is being created for that also. And that is necessary. If at all, if you have a will to do it, it is possible for that. So two vital characteristics for surgeon is necessary. One is a decision, second is a dissection. The decision and dissection are important. You may be very expert in dissection. It's just a craftsmanship. Anybody exposed many times, even a non-technical person habituated with you, assisting you, will want the same pattern, they will dissect it. But it's just a craftsmanship. That is not surgery. I think the decision is important. Where to do surgery and what modalities of surgery do. And in such situations, if there are some problems, how to manage that, that is important. And therefore, I feel all of you are doing that, but none of you are focusing on these two aspects. Today's episode, I'm just highlighting and focusing on these two important aspects of surgery, decision and dissection. If both are good, the quality of surgery is good, and you are designated as surgeon, not the operators for that. So what are the decision making for gynecological surgeries? There are different components of decision making for ectopic, and there are different factors, different methods, methodology and SOPs for that. First of all, an optimum knowledge is required. Acquiring an optimum knowledge on that particular subject, on that particular surgery, one should have acquired optimum knowledge. That's first priority, first important criteria. The knowledge may be by various sources. There is no depth of knowledge, information and all that, but there are various sources, and starting from the workshops or associated with the good surgeons and training, all these can be acquired for that. Now, medicine is a dynamic subject. Surgery is a dynamic surgical field. The techniques are variable. The methodology are variable. The technology are coming day in and day out in a new forms for the benefit of the patient. And therefore, updating the knowledge from time to time. You have to update yourself. What I believe myself when I started this surgery, initially, we have never seen a laparoscopy endoscopic procedure. We have never seen a ultrasound methodology for that, for diagnosis. We have started with that. And the endoscopy came, the different techniques have changed in that, modalities has changed in that. And therefore, one must adapt to the different changes. Maybe that in future, every day this is changing, and every surgeon must keep abreast with all the changes which is necessary for improving the quality of life and quality of surgery. This updating the knowledge from time to time is important. And of course, the mentors association. I've always tell that surgery needs a mentor. It needs a guru. I think Teachers' Day, therefore, is important. It needs a guru. If a mentor is good and you are being associated with the mentor, good mentor, your quality of decision as well as dissection will be equally perfect for that. Lessons learned from past. We do err is human. I think we're liable to make error for that also, because of there are several reasons, and you are liable to make mistakes. So mistakes and lessons learned from past, you should have a deep introspection and observation, and so that it can lead in future for that. So you always learn from your lessons. From if you're doing a surgery and there is a problem, you learn that. That could be a guide for the next cases for that. That's important. Avoid bias and emotions. There are various bias. While deciding a particular case, the bias could be there. The patient will put pressure. the party will give pressure, the hospital will give you pressure, the other thing, the commercial aspect will give pressure for that. So avoid bias, avoid emotions while doing a decision making in gynecological surgery. You be above all these factors, and these are all affecting the bad decisions, and always you are not doing a good job if these are bias and emotions are there in your mind. Second opinion, if necessary, you take it. This is important. So second opinion at times is important. At many times you are not decisive on a particular methodology, what you should do it, whether you should do it or not, in which way you should do it. You ask, there is no ego. You sacrifice your ego. You have a second opinion, either a friend of yours or a teacher of yours or a colleague of yours. You take a second opinion of the persons for that. Help from other faculties. Many situations of surgery, we need help from general surgeons. The GI surgeons could be necessary. Urologists could be necessary. So, and we are dealing with the anteriorly, the urological part, posteriorly, the rectosigmoid and the intestines and other thing, appendix and all these. So, help from other faculties. There is some of the problem. There is a problem of diagnosis where you suspect that there could be need of a helping hand. You take help from these faculties. There is no ego, sacrifice all this ego in decision making for that. Then understanding the basic surgical philosophy and synthesis of theory and practice. This is important. Understanding the basic surgical philosophy you should understand. And many people tell that theory and practice are all different. Don't segregate. I am different of views on that. Always theory, applied theory is practice. Without this applied theory, you cannot grow also. You cannot do a right job in surgery for that. And therefore, you amalgamate and synthesize theory and practice. And of course, along with that, the third is research. Converting research into practice, that's also important in making you a real worthy surgeons of the future. One of the very important things, decision not to do surgery. This is important. You decide. It's very easy to decide for surgery, but it's very difficult to decide not to do surgery. And I always tell, it takes 5 years to learn and do the surgery, but it takes 25 years to learn not to do the surgery. And that is very important. In all cases, any pathology or any surgical abnormality can be cured by surgery. It's a wrong idea. So therefore, you decide where not to do a surgery. And that is important. Thinking of alternatives. You find that there are various modalities of surgery and various alternatives of surgery. Think of that alternative, whether in this particular patient, whether there is a place of alternative. This thinking will change your decision, and this thinking will change your right decision also. And selecting the right modality of surgery for that patient, it's important. If there are 3-4 modalities of surgery for that particular patient, the right modality of surgery you adopt for that. Say, for example, hysterectomy. You see that there are 3 methods of doing a hysterectomy. Either you can do open methods, or you can do a laparoscopic, or you can do a vaginal. You have to find out which modality of surgery will be best for that particular patient. And that is important. It's not the question of the ego. It's not the question of your own whim or mood of your people. It is the need of the patient which is most suited for that. So therefore, don't abuse. I think the modalities of surgery will be the need of the patient. Wherever this particular modality is good, a route of delivery of the uterus is absolutely genuine for that particular patient, adopt that. That's a good decision. Then therefore, if you're not doing that, it's a bad decision. Ultimately, it is affecting the future of the patient. 2 things are very vital. I always say that I am a doctor. People come for a problem to me. And what for I'm here? I have to solve the problem. I have to find out a solution. And anything, either a medical or a surgical, patient comes and contact you and complains various findings for that, shows all the investigative reports for that. Even they are prepared that, mentally prepared that for a particular surgery for that. But you don't be out of focus. You always target the problem. You identify which is the problem, and I'm there to find out a solution for that problem. I may not be able to do it, can't say, but I will try my best to find out a solution for that. That is the ultimate theme of a doctor-patient relationship. The technical theme of ultimate theme of a patient-doctor relationship is that patient has a problem and doctor has to find a solution for that problem for that. And every problem has a solution. The intricate mechanism of finding out the solution depends on you. And that is why all these teaching process, all these workshops, all these gurus, sishyas, learning, training, everything is bound up with all these procedures. And you have to apply your own brain, what is best for that particular individual for that. Now, second, after decision making, you have done a good decision, then a dissection is an important part. There are various types of surgery, various types of dissection modalities could be there. An individual dissection also varies as per surgeon to surgeon. And all are good. There is no deniance on that. Surgical dissection varies, but a standard surgical philosophy with the limits of the dissection, you have to do it. So what are the principles of dissection? Understanding the surgical anatomy and altered anatomy. I always say surgical anatomy is there, but more important is to understand the altered anatomy. Suppose there is a altered anatomy because of a congenital nature or because of an acquired previous disease. There could be altered anatomy like endometriosis. There is an altered anatomy. Previous surgery like a cesarean section, like a myomectomy, there is an altered anatomy for that. So therefore, basic surgical anatomy as well as altered anatomy is very, very important to understand that. And therefore, your dissection will depend on these two important factors. Now, understanding the pelvic space and avascular plane. Correct me, it's not a place, pelvic space. The spaces in pelvis, I think there are very, very important spaces in the pelvis where avascular plane is there. And that space, if you ask an oncologist, they're doing day in and day out oncologic surgery in pelvis, and pelvic oncologic surgeons are familiar with the different spaces. And pelvic space, but definitely avascular space. A parietal space is there, space of Okabayashi, and other spaces in the pelvis, lateral pelvic wall. There are various avascular spaces, avascular plane which is there, retroperitoneal dissection. There could be avascular plane could be there, and that you have to understand that as a pelvic surgeon, as a gynecologist. This is not only for oncosurgeons, but for a gynecologist also. This is important to understand the pelvic spaces and avascular planes. Identifying the proximity of adjacent organs and vital structures. Say for a gynecologist, we are the vital organs and structures. One is the bladder, another is a ureter, rectosigmoid, and the vessels and nerves on the lateral aspect. These are the main vital structures. And these vital structures could be altered by the anatomical change in pathology or because of the previous surgery. And you have to understand that, because the surgical plane of dissection, if you go through this, I think surgery becomes very easy and procedure without any mess and all that. Otherwise, if you do not enter into a perfect avascular plane, your total surgery will be a mess. And therefore, this is important, and that is the importance of a dissection, to understand that. And injury could be drastically reduced. You are not going to damage the structures for that. Again, fat in the pelvis, I respect. This is a safeguard for gynecologists for that. Fat in the pelvis. We know that fat doesn't belong to the gynecological organs. That is the fundamental principle you remember. Fat doesn't belong to the gynecological organs, meaning thereby fat in the pelvis either anteriorly belongs to the bladder or posteriorly belongs to the rectum. This is the fundamental principle, and this is the truth. So while dissection, if you identify the fat and remember that this fat doesn't belong to me, this fat doesn't belong to the uterus, you go in that plane. Otherwise, you are entering into the plane closer to the rectum or closer to the bladder, and there is a likelihood of damage to it. This is the fundamental principle. Any gynecological surgery, let it be endoscopic, let it be open. Remember this, fat doesn't belong to the gynecological organs. Fat belongs to the rectum, fat belongs to the bladder. Hemostatic dissection, always in a dissection, if you go to the avascular plane, the hemostasis will be maintained for that. That's number one. And if at all there are small tweaks, that must be coagulated at that particular moment, right from the beginning, so that a hemostatic dissection could be there. So along with the dissection, some of the electrosurgical principles could assist us, could help us in dissection for that. And then understanding your limit of dissection. You should understand up to what limit I will dissect it, beyond what I don't require to dissect it for that. That's important. Don't over dissect. Whatever is required up to desired for that particular surgical technique, you do that. And that limit of dissection you must understand, you must find it for that. Then of course, blunt versus sharp dissection. Dissection could be blunt. There are blunt dissection by the finger, blunt dissection by the gauge. These are all blunt dissection for that. And some of the hand instruments, blunt dissection could be there, but sharp dissection is also of value for that. And that, if you are entering into an avascular plate with the sharp dissection, I think it's a very easy surgery, looks nice, the quality of surgery will be good, and the morbidity and mortality will be less for that. And of course, handling appropriate instruments. You should know what are the instruments that are used as a dissection. I will just narrate the common thing which you are using it. I will just focus it. I will just make it view for you and give an emphasis on you that these are the instruments that is designed for, maybe for some other reason, but this could be helpful for dissection. And you have to be able to handle those appropriate instruments for that. Now, next is there are some facilitators for surgical dissection. Some of the procedures, some of the methodology facilitates the surgical dissection. We know the plane, we know the space and all that, but some of the, like aqua dissection. Aqua dissection is very popular in laparoscopic surgery. So aqua dissection was very popular in laparoscopic surgery because this is not same as hydro dissection. Aqua dissection is something different than hydro dissection. Aqua dissection is a method where by suction irrigation cannula, under pressure, the water pressure will dissect it, and that will go through a very avascular place so that the bleeding will be less. So aqua dissection in pelvis, particularly for laparoscopic surgery. But hydrodissection is very important for vaginal surgery, where you want to give a space, find out a space. This is important in vaginal surgery. Vesico-vaginal space is very, very important. Vesico-cervical space is very, very important for that. And while doing a vaginal surgery, particularly for a prolapse, you have to do a hydrodissection. You have to do a hydrodissection with or without some of the vasopressors, but this is essential. Simple hydrodissection will have normal saline, also infiltration without adrenaline or vasopressin, also will be separating the particular plane and avascular plane where the bleeding will be less, and you can easily dissect it very well for that. And in some cases, or majority of the cases, we are using the hemostatic agents along with this normal saline. We are adding adrenaline 1 in 1 lakh or vasopressin 20 units in 100 ml of the normal saline or distillate to dissolve it, and these hemostatic agents can be infiltrated either by laparoscopic surgery or in the vaginal procedure. You can infuse that, or if in some of the cases where we find that the patient is hypertensive, we simply, without adrenaline or vasopressin, put it the normal saline for that, and that will create a good space for that. And in laparoscopic surgery, this is absolutely mandatory. We use it regularly, vasopressin injection before myomectomy. That will not only arrest the hemostasis, but a space will be much more better for that vasopressin infusion, and that's important. Even in endometriosis, also in grade 4 endometriosis, you just infiltrate vasopressin on the posterior surface of the uterus in a grade 4 endometriosis, and then start a dissection. Dissection is facilitated without a mess and without a bleeding for that, and that is being advocated. I always propose that that always do that procedure, even in grade 4 endometriosis. The things which you say that is inoperable, it will be operable by this infusion for that. Now, for laparoscopic surgeon again, pneumoperitoneum is very, very helpful in lap surgery, particularly if you're doing a radical surgery and extensive surgery in the pelvis and lateral dissection. The pneumo helps us. As you dissect, the pneumo enters into that, and that space is more clearer than if you compare with the open surgery. The same case, radical, suppose we are doing it laparo as well as with the open surgery. Because of the pneumo, the space are created, augmented, and that is an advantage of the laparoscopic surgery, particularly for the radical procedures in our field. Then, of course, electrosurgical device and harmonic. The power in surgery which you have it. We have already discussed one episode on electrosurgical devices and electrosurgery in gynecology. Again, I will emphasize that these electrosurgical device is not only helping in vessel sealing in doing a hysterectomy, favoring hysterectomy, other thing, but in dissection also. In dissection, particularly brightest example I am giving you, that in nodal dissection, pelvic node dissection, we use the electrosurgical device, the simple bipolar, we dissect it. Or in a case in abdominal also, in hernia repair or in scar endometriosis or in any surgeries, these could have, in addition to hemostasis, this could be helping in dissection. And of course, harmonic is a very good dissector because you don't want to change the instruments. The instruments are not changed. You have a laparoscopic hand instrument and dissector is there, but you can use the unipolar with that. But the harmonic, you act as a dissector as well as a hemostasis, and therefore this is important. Electrosurgical device, harmonic, the shear, these are all in addition to the electrosurgical device, it helps as a dissection for that. And of course, one of the beautiful, I think, and the dissection process is a traction and counter traction. You have to go to the particular place and space, and then a traction and a counter traction. May it be open, may it be laparoscopic. By traction and counter traction, the things are very, very easy, and these are all, I call it as facilitators of surgical dissection. You are using it, but I'm just focusing it and outwardly expressing it before you today. What are the instruments for dissection? The instruments for dissection, there are various instruments for dissection. Ladies and gentlemen, frankly speaking, I consider the surgeon's finger is the one of the best dissector ever possible. The safest instrument is a finger's hand, surgeon's hand, surgeon's finger. Surgeon's hand and finger are the best and safest out of all the instruments for that. And therefore, I consider this is very, very important. More so, our lady gynecologist. We say that lady's finger is absolutely better than the man's finger for that, as far as the dissection, because we can be hard for that. A man's finger can over dissect, but the lady's finger cannot over dissect. They know the limitations for that also. They're soft. So therefore, surgeon's finger, I say that they are one of the best instruments possible and the safest instrument possible for dissection. And many, many cases, all of you are using this. All of you are using this dissection. I'm just expressing this and just reminding you all this. Gauze. A simple gauze can be a better dissector. In vaginal surgery, you put a dissector and a gauze. Or your MUP, you are using a myomectomy. You are just separating. If you are going to the proper plane of cleavage and just dissecting it like a stripping up the coconut from the cell, you do that. And that's exactly through the proper place you go it, instead of dissecting by the scissor and cutting it on all that. Scissor is also a very good dissector. Believe me, but a proper plane, you have to go it for that. A scissor dissection is absolutely good. If you're going for a ureteric dissection, scissor dissection is important. But the way the anatomy is important for that. The anatomy is scissor dissection. You see, giving an example of ureteric dissection. Ureter always dissect not perpendicular to the ureter, in the same plane, in the horizontal plane, lung and the course of the ureter. If you dissect it, I think that is nothing. I think this is the safest procedure. If you are perpendicular to the plane, then there will be a problem for that. And therefore, the anatomy you understand. and therefore you dissect with the seizure. Seizure, a gland dissection or any dissection by seizure is absolutely, while dissection of the uterovesical pouch, of the posterior peritoneum, whatever you do, the seizure will be a very good dissector as compared to the blunt dissector also. Wherever there is a place for blunt dissection, you do it. But seizure dissection can be, you should be used before the blood. There are some demerits of blunt dissectors on that. I will show you in my video what you will do that. Surgical blade, the blade where the cutting is necessary, you can also scrape it and dissect it for that. Speculum, our sim speculum, or even our single-bladed speculum is a best dissector. You see, like the common example I'm giving. Say, for example, you are going for a vaginal hysterectomy. You just push the dissector, put the speculum in the interior UV space or in the posteriorly. And even if the posterior pouch, there is a adhesions and all that, closer to the uterus, identify and put the speculum. It will ultimately separate you to a long distance and dissect you for that. Same thing happens with the anteriorly. But remember, you have to find out a space, right space, you have to introduce it. Otherwise, if you push it with the speculum, it will go through the bladder. If you push it with the speculum, it will go through the rectum. So remember, initially you find out a space, and then after that a space is there, you just push it in that particular space. Absolutely, the dissection in that plane will be go and onwards and onwards. Same thing with the anteriorly, while opening the uterovesical pouch in a case of hysterectomy or some other purpose for that also. Either endoscopically also you can do it for that same thing procedure. But endoscopically you cannot put a speculum, but in open surgery you dissect it, put a speculum, and ultimately the bladder will be dissected in a correct plane for that. And that's why I consider speculum and retractor helping as a dissector. Myoma screw. Yes, myoma screw in extensive adhesions of the uterus, when you are using particularly myoma screw, not only helps in giving a traction on the uterus, but putting a traction on the uterus, the adjacent adhesions on the posterior part or the anterior part will be easily cleaved, traction, and just with the finger that can be cleaved for that. And that's why I say that myoma screw is a very good decision. Same thing with the myoma screw used in myomectomy. The myoma screw, if you use it in the myomectomy and to the proper cleavage you identify and then put the screw, and with that cleavage, you can enucleate the myoma completely avascular for that. These are all instruments for dissection. I'm very fond of this suction irrigation cannula in my laparoscopic surgery, particularly the endometriosis, particularly if there is an adhesion. I think these are the cases without aqua dissection also. Suction irrigation cannula can be a very good help, particularly for dissection. Number one reason is that the main factor of this is that you can dissect it. It's a blunt dissection. It's not a sharp dissection, but it can go because this suction, if there's a bleeding, you can suck it and find a good space so that you are entering in a proper space or a defective space, you can know it for that. And irrigation and suction both combiningly can help you in identifying, in visualizing the space and giving a correct plane of dissection in the endoscopic surgery. For endometriosis, this is my very, very favorite instruments for that. I don't want to catch it with the sharp dissection. I don't want always with that. This is a very important thing. Corp Caesar, corp dissector, laparoscopic dissector, dissecting force. I think these are the dissecting corp dissectors are there. Harmonic shear, the shear which is harmonic, I have already told, harmonic is a very good helps in dissection along with the cutting. And nowadays, electrosurgical device, shear is also there. The various Indian companies, Alan, PV and other things, they are manufacturing this shear, which I have in the electrosurgical principles, I have demonstrated all this. This could be acting as not only the delivering the electrosurgical energy, but is a very good dissector, helping as a hand instruments in particular. Another myoma separator. I'm very fond of this myoma separator. Again, India genius indigenous. One the myoma screw, myoma separator. All these are Indian people, Indian companies are manufacturing. I bought it from PB Bimal Sa, and therefore I've used it. Myoma screw is a very good dissector for that, because if you can dissect to the other instruments, but this is a very cheap instruments and very stout instruments. Other instruments they can break, and these are all costly equipment for that. And therefore, myoma separator, I will demonstrate how the myoma separator can be used for a myomectomy. And this is particularly for laparoscopic surgery. And of course, there is no limit of these hand instruments, which you can use it for a dissection purpose according to your own choice, the surgeon's choice. They're how far they are more, I think, favorable, or how far they are more comfortable with this particular surgery for dissection, and they will select that particular instrument. Now coming to the clinical scenarios, dilemmas, starting with the dissection and dissection. Decision, I think I've already told what are the decisions: where you do the surgery, where you do not do the surgery, where you do the out of all the three surgery, which surgery has to be employed for that. I've already briefed you in my previous few minutes of my deliberations. Today, these are all practical scenario, clinical scenario or dilemmas which I have faced in my life, and that's why I wanted to present before you. Now, situation one. Long back, I was a first year postgraduate. Way back in 1980s, early 80s. 45 years, para 4, all spontaneous vaginal delivery, normal cycle, swelling of abdomen for last 6 months, and pain for 2 months. Bowel, bladder normal. On examination, we found cystic lump of about 32 weeks, mildly tender, Porspeculum cervix healthy, PV uterus size not elicited. Of course, it cannot be, and furnace is free. So a clinical diagnosis of ovarian cyst was made. There is no sonography at that time, and in a pre-sonographic era, only everything rests on our clinical diagnosis. So this case was diagnosed clinical as ovarian cyst, and my professor told that you put it the next OT for laparotomy. So accordingly, as a postgraduate, first year postgraduate, we are all prepared for that, and anesthesia spinal was given. My professor was ready with the globes, and as a first year postgraduate, your job is I always say, you are master in catheterization and Doyen master. These are all DMMC degree, you get it in first year postgraduate. You have your only role is to put the case and put the catheter. You are not allowed to assist also, first assistant or maximum up to second assistant putting a Doyen, holding a Doyen. That was the thing. We are ready, surgical team ready for surgery. And I was the first person who tried to do a catheterization. When doing a catheterization, I found 3 liters of urine was drained, tumor disappeared with all our presence. Then I examined and asked my professor to examine. Uterus mid position, bulky, firm, mobile, furnace free. And everybody was ashamed who we are, what diagnosis we have made it, what decision we have made it. Indwelling catheter given, patient transferred to the ward. So what message we are giving? Pitfalls in clinical diagnosis. So pitfalls in clinical diagnosis, and in a pre-sonographic era, I salute my teachers who have done it mainly by clinical sense diagnosis and all that. And these are all pitfalls in diagnosis. Chronic urinary retention with normal bladder function, not uncommon. Sonography has a revolution as a diagnostic armamentarium. We are taking credit that now we are easy for that. But where is your hand? Your hand is lost. Hand has been replaced by a transvaginal probe. Tech versus touch. This is not important. This is not also good. Tech and touch should be blending of that. One should blend both of these. So principle of routine catheterization, we do in gynecology. We say that all you catheterize prior to do surgery. All cases, you put a catheter. That is the imprint which is there with all gynecologists. Old, recent, and would be also for that. So therefore, by doing this, the gynecology, this procedure has saved this patient from surgery. This is really unique. I cannot forget this particular case in the pre-sonographic era. I contemplated this particular case to another case of mine. One of my student who was there in the periphery, he rang me after 10 years of this thing and all that, where even sonography was earlier there. At that time it was there. And in this rural area, the gynecologist called me, sir, there is a case of ovarian cyst. I will send it. I told her, why don't you do it? No, sir, there is hydroureter and hydronephrosis, and that's why I wanted to do it. I remember this particular case of chronic urinary retention or a chronic obstruction. And I told, do a sonography. No, sir, sonography is not available nearby. I can't do that. And I told, if you not, I will send it to you. I told, if you do not have a sonography, at least put a catheter and then examine the patient. Believe me, he put a catheter and then absolutely this is again a case of full bladder. And this has resulted in backflow, giving rise to hydroureter and hydronephrosis. I said that you put an indwelling catheter, keep it for 21 days, and the patient will be all right for that. So these are the cases where how the decision changes, how the decision is not in favor of surgery. I've learned that, and over the years we should learn that. Situation 2, 38 years, para 1, widow, again on my second year post-graduation. I'm just taking all of you, excuse me, to my second year. So para 1, a widow, presented with 4 months of missed period. And the lady constantly telling confidentially to me that there is a history of contact. I've done a blunder and all that. Please excuse me, but this is because of it. So the immediately with the 4 months of missed period, with a history of contact, I find uterus is 18 weeks and there was no sonography again in a pre-sonographic era. And she wanted, of course, unmarried, widow, plan for MTP. So I told my professor that she has a history of contact and 4 months missed period, size is 18 weeks. And sir examined and found out you give an extramyotic ethacadine lactate. At that time it is given. And 3 days, nothing came out. Then professor advised again to give intramyotic saline. At time intramyotic saline or ethacadine again to give it. Again there is a dry tap on 3-4 sittings. I tried it as a dry tap. And I told I'm really inefficient. I'm in a second year care. I've passed 1.5 years, but I'm not able to find out and give an intramyotic installation. And therefore, I felt very sorry. And then my professor told that you plan for hysterotomy. At that time, hysterotomy was being done. Now, no question. We are not we are even for that has gone to the graveyard 20 years ahead. It was done routinely, hysterotomy. So hysterotomy as a surgical methods of mid-trimester abortion was a method at that time. It is a plan for hysterotomy. And laparotomy was done. I was assisting, my professor was doing. Uterus was enlarged, firm in contour. And he gave an incision over the uterus. In hysterotomy, we gave a classical incision in the uterus. And instead of a fetus, a solitary intramural myoma with degeneration came. And then my professor had done the hysterectomy. I was assisting. Patient discharged with uneventful recovery. So what we learn? Message, pre-sonographic era, only diagnosis is based on clinical parameters. And this particular case, the history has misguided us. Pitfalls in clinical diagnosis, we know that a more commonly it's a degeneration so that the uterus looks soft on palpation also. But still, I say salute to the yesteryear's gynecologists and our teachers for their clinical acumen. They are superb in clinical acumen. They diagnose 99% of the cases by clinical methods. 1% could be missed, and that sonography or other measures could detect it further. But 99% the clinical methods. Today, we lose the clinical scenario in such a method. We cannot diagnose clinically. We have to depend on some investigative gadgets for that. And therefore, imaging science is now a boon for diagnostic modality. Revolutionized the concept of diagnosis of the diseases and therefore the decision making also. Situation 3, 20 years unmarried girl, irregular cycle, has gone for master health checkup in a corporate hospital. And sonographic evidence of ovarian cyst. The sonologist gave an impression that there is an ovarian cyst in the right ovary 4 centimeters. And therefore, it's because it's a corporate hospital. They have planned for lap cystectomy, opted for second opinion. Unfortunately, she opted for second opinion. And I examined, clinically absolutely normal, and explained regarding the difference between ovary and cyst and cystic ovary. I say that cystic ovary is there, and in my view, surgery is not necessary for that. I gave a 3 cycles of COC, repeat sonography normal, patient was happy. Not that the COC is the treatment for functional. She think that by medicine my cyst disappeared. No, it's all right. Without also that, in the over a period of observation, the cyst. But these are the functional cyst. But thinking to a functional cyst and knowing fully well that it's a functional cyst, if you do a surgery, I will feel that it's a criminal offense. Maybe the decision may be because not a technical decision, because of some commercial decision, because of some pressure by somebody. I think the gynecologist must have decided for that, refrain from that. So this is a problem of master health checkup, functional cyst versus pathological cyst difference should be there. And no need for surgery in there. And counseling is enough for that. So therefore, there could be many, I think, pressures for that. There could be many bias or many causes for that. But refrain, don't be commercialized for that. And science, as per the evidence, as per the scientific knowledge, you apply your thought and surgery for that. And ignore, not for commercial purpose, I will do this surgery for that in life. Again, 26 years, married 6 months, oligomenoid cycle, mildly obese, not keen for conception, sonographic evidence of polycystic ovaries, very much panicky, and keen for surgery, because the radiologist, the sonologist has told that there are polycystic ovaries full of cysts, and therefore her brain is full of cysts, and therefore she was very panicky of surgery. Surgery is required. Counseled. Lifestyle intervention, PCO is not a surgical condition. Plan for pregnancy, and if at all you do not have that, because of the oligomenoid cycle, investigate, and ovulation induction at best could be required for that. But don't think of surgery now. This is the situation 4. And therefore, such presentation by patients not uncommon, and counseling mandatory. Some of the patients, they come with the prefixed idea that you do the surgery, you do the hysterectomy. If there is an excess discharge, I will develop cancer, you do the hysterectomy. I think absolutely you examine and find normal. You don't do surgery. These are the patients, from the patient's pressure, you don't do the surgery. There are some patients who always request that, yes, either themselves or by some other persons, they have been pressurized. They are told that, yes, if you do not do the surgery, it will grow, it will burst, and it will go malignancy. All these will create a lot of problem and panic for that. So therefore, counseling mandatory. And you should know no role of surgery. You should find out decision. Again, I am again repeating this. You should know where not to do surgery for that. Situation 5. 26 years, married 3 years. Keen for conception 1 year. Normal male factor, normal cycle. Sonographic evidence of myoma 30 millimeter and 20 millimeter in fundus. Always, if you see a sonologist report, they will never say that 3 centimeter or 2 centimeter. 30 millimeter, 20 millimeter myoma, tumor. These are all imprinted in the mind of the patient. They are all really horrified with that. And in the last, they write 2 sentences. To be clinically correlated and not for medical legal purpose. These are the usual sonography report which till date I am seeing by the radiologist for that. So this particular case was behaving like that. There is absolutely no problem accepting the keen for conception. So they think that because of the myoma, the infertility is there, and infertility, the myoma might grow and might cause some problem for that. So I told abandon planning of surgery. Find out other causes of infertility. And this couple conceived spontaneously on eventful antenatal and intrapartum period. So myoma and infertility, $1 million question. Is very common, but decision to do a myomectomy for fertility augmentation is absolutely a big question mark for that. That depends on the number of myomas, on the size of the myoma, on the location of the myoma. I don't say that some myamas may cause subfertility or may cause a pregnancy loss, but asymptomatic myoma usually is not associated with the infertility for that. And in myomectomy also, I have absolutely showed you, in those cases, don't go for surgery, and not to do, treat or not to treat surgically myomectomy is a big question mark. And all of you should be convinced that there are some situations, if you relate that the myoma is causing infertility, then do a myomectomy. Otherwise, say no to myomectomy. 27 years, primigravida, presented with pregnancy at 9th week with myoma. Again, this is a very common situation all of you must be seeing. 9th week pregnancy, uterus 22 weeks, irregular, and on sonography there are a myoma and pregnancy. And clear-cut single live fetus in 9th week is on sonography with multiple myomas, subserous myomas of varying size. They are keen for MTP. Somebody advised that yes, there are a lot of myomas with this 22-week size. Number one, the myoma size will grow and the pregnancy is going to be affected. These are the two impressions which is given to the patient. And therefore, they wanted that you do an MTP followed by myomectomy and then plan for the second pregnancy for that. This is a very common. I counsel to continue the pregnancy. There are a number of cases of this which go uneventful, and therefore counsel to continue. Explain regarding the effect of pregnancy and myoma and pregnancy. If it is a spontaneous abortion, it's all right. That doesn't matter. But you explain the risk of myoma on pregnancy and on pregnancy or myoma, both ways you should explain. The size of the myoma can increase, the pain could be there, the discomfort could be there could be abortions, there could be preterm labor, there could be malpresentations, all these. But remember, this is not an indication for surgery. So pregnancy continued, uneventful antenatal period, spontaneous vaginal delivery, male baby 3 kg. So pregnancy with myoma is not uncommon. Termination of pregnancy is not indicated. Most of the cases are uneventful. Vaginal delivery peculiarly is possible. And if at all you are doing for cesarean section because of some other causes like a transverse lie, malpresentations, breach or other things, then you can do a cesarean myomectomy at that particular moment. I have already shown the different techniques of cesarean myomectomy for that. 25 years, primary infertility 1 year, oligomeric cycle, sonographic evidence of PCOD, DHL with LOD done elsewhere. She has done in somewhere else. Some doctor has done a DHL with LOD. Presented with pain abdomen after surgery. Male factor normal. Female, no other investigation has been done. Straight away, primary infertility 1 year and sonography PCOD, oligomeric cycle, and again putting a scope. This was the intervention, surgical intervention. You decide how far it is justified. To do DHL, number one. Second, if at all diagnostic histoolaparoscopy, you do it. To do LOD in the same sitting in a 25-year infertility 1 year, that's really a big question mark. You decide what to do. So counseling done after all these procedures. And then example, this is a clear-cut example of a wrong decision. Why DHL 1 year? Invasive test for a tubal factor. There must be some assessment, some of the indications for diagnostic histoolaparoscopy. Remember that. And otherwise, too early 1 year, you can do an HSG for that also for a tubal investigation. Why do an investigation, invasive investigation? DHL is indicated in my view. Duration of marriage, duration of infertility, age of the woman more than 35. If it is there, then you can do it. But age of the woman, duration of infertility more than 3 years, previous treatment underwent, and some of these signs suggestive of the dysmenorrhea or other things suggestive of pelvic endometriosis or sonography evidence of pelvic endometriosis. Rather, you plan it for that DTHL, diagnostic as well as therapeutic. But the question of LOD is a big question mark for that. All cases do not require LOD, and this is a wrong decision of the budding endoscopic surgeon when they see the pearly white beautiful ovaries. there is an irresistible desire to make holes and holes all over the ovary and burn the ovary. And to such an extent that you do an AMH, it will be less than 1 after 2 months. And not only that, the extensive peri-ovarian adhesions will be there. So a probable normal ovary which is able to conceive by ovulation induction. Now you land in reduced ovarian dissolve, number one. Second, there is a lot of adhesions all around, so that ovarian factor will be transferred to tubal factor for that. So these are the demerits which people know. The decision is important. Future prospects of fertility is a big question mark. So this is an abuse of diagnostic histolaparoscopy in that. And there should be clear indications of laparoscopy. Abuse of LOD. Again, there must be clear indications of laparoscopic ovarian drilling. Otherwise, don't do it. This is an inadequate knowledge or biased by something else. This is the interpretation. A rational evaluation of couple for infertility rate. Resort to surgery is inadequate knowledge and other factors. Definitely, there could be other factors for that. And suppose fertile couple will land in sterility, and that too iatrogenic. And apparently, fertile couple you convert into sterile couple with your surgical intervention. So wrong decision, wrong surgery has to be condemned, and surgical introspection is needed for the future. 40 years para 2, both LSCS, normal cycle, sonographic evidence of multiple cholelithiasis with a left broad ligament myoma of 4.6 centimeter diameter. So she came to the general surgeons for the upper abdominal pain, indigestion, dyspepsia. On sonography, abdominopelvic scan, this sonography, there is an incidental finding of a 4.6 centimeter left broad ligament myoma. There is absolutely no symptoms. The menstrual problem was absolutely normal. No pain, no urinary retention, no pressure symptoms, nothing. So she thought that most probably I will do, because there is a myoma, I will remove it. No, it's not because of a surgical diagnosis or a pathological diagnosis you do a surgery. I think that's not a good decision for that. So I advise not to go for hysterectomy in view of asymptomatic and incidental findings. Lab call done by a surgeon, follow up after 1 year, absolutely normal, patient doing better. So I think these are the cases you should remember where not to do it, surgery. An asymptomatic myoma is not uncommon. Surgery is not at all advisable. Follow-ups are necessary, and myoma, treat or don't treat, remember that for that. If it is a symptomatic myoma and a cholelithiasis, yes, there is you should do a joint venture. You can, in an era of minimal invasive surgery, both can be done in a single sitting, one by the surgeon and the hysterectomy by you gynecologist can be possible. Otherwise, asymptomatic, incidental finding, don't operate, say no to surgery. 35 years para 2, presented with persistent pain abdomen following surgery and severe menopausal symptoms. They presented to me with the severe menopausal symptoms, flossing spills, and persistent pain abdomen. And when I found on history, there was a history of laparotomy, and that laparotomy was done by an oncosurgeon. And I saw the reports, brilliantly written, details of that has been written. History of laparotomy, there is done, when I find there is a long scar and bilateral endometriotic cyst with increased CA120. CA125 was more increased. And therefore, the oncosurgeon told that, yes, it is a cancer, you must do a surgery for that. And long midline incision from supraumbilical to mons pubis, I found it. And operative findings in the note, it has been written: abdominal hysterectomy with bilateral salpingo-oophorectomy, omentectomy, and bilateral pelvic lymphadenectomy, and para-aortic nodal resection. Everything has been done because he's an oncosurgeon. He's excelled in that field. And histopathology report is also included with that. Endometriotic cyst ovary, normal node, and omentum was normal. What is the message? This is just a brightest example of showmanship of surgical excellence. It's not science. It's not ethical. It's not rational. It's not scientific. Because we know that endometriotic cyst, when you do a CA125, it will be raised. And by single parameter of CA125, malignancy thought in a very young age of about 35, 36. inadequate knowledge and wrong, and that too pelvic node dissection, paranoid node dissection, omentectomy like a cancer. Inadequate knowledge and wrong decision cause a patient suffering forever. At best, you could have done some surgeries, not this extensive surgery for the ovarian cyst for that. 36 years para 3 with excess discharge PV with previous normal cycles, planned for vaginal hysterectomy with PFR, and opted second opinion. She came to me. When I examined, I find a perspective cervix is paras healthy, but there is a first degree descent. There is a descent. There is a first degree descent. There is a small rectocele, and there is little excess discharge. I told you, you don't need a surgery. Counsel not to go for surgery. Treated for vaginitis, happy in the next follow-up. Remember, asymptomatic first degree descent with excess vaginal discharge is not an indication for hysterectomy. Remember, when there is a symptom, she doesn't have a symptom of prolapse. She's having an excess vaginal discharge, and on finding, you find that there's a first degree descent. Believe me, these are the cases which many surgeons do also, but today, where not to do, you should learn. And these are the cases where you avoid the surgery. And this mostly seen in paras women, this first degree descent. So first degree descent doesn't require any surgical entity for that. Counseling is necessary for both patient and doctor. The doctor has also to be counseled that yes, this is not an indication for surgery. Wrong decision. 30 years para 1 underwent lap cystectomy, right, 10 centimeter. This is my own case. 10 centimeters with a serous tumor, and I clearly do, and it's a very easy surgery and enucleated, and cyst was in a very avascular plane, and sent it for HP study. I was surprised to see the report. It is a 30-year-old lady, para 1, cyst dissection was very clear. I didn't expect the report to be papillary serous cystadenocarcinoma. I was surprised. I asked my oncologist friend, plan for revision surgery, and I insisted on review of HP slides. Not only the HP slides, but I went to the laboratory personally, to the lab, and find out the whole day, whatever samples you have received, all the samples to be screened, scanned, and again sorted them. Remember, I was lucky to find out that in the lab, it was confirmed that the slides was changed with another patient. See how dangerous is it. And I could find out if I would not have gone personally, and I would not have insisted on the whole, all the slides on that particular day, whichever you have received it, I want that everything should be evaluated for that. And then review of slide came. It is a serous cyst. It's not a malignancy, serous cyst. I was not, because clinical, there is no suspicion of malignancy also. Laparoscopy procedure also, there is no suspicion of malignancy also. So no correlation between HP and clinical as well as surgical findings. One should be very meticulous at all levels, including the ID numbers in laboratory also. Luckily, patient saved from revision surgery. Otherwise, should have gone for a revision surgery and a radical surgery in a 30-year-old lady. An absolutely non-indicated surgery. And the consequences. 48 years, para 3, all spontaneous vaginal delivery. Irregular bleeding PV for 3 months. Previous cycles, menorrhagic, obese, vaginal hysterectomy done elsewhere. HP report came carcinoma endometrium, grade 1, but more than 50% invasion to the myometrium. So we had to do a revision surgery. And revision surgery was being done by my oncologist friend, Dr. Giri, and bilateral lymphadenectomy with bilateral salping oophorectomy, we did it. Laparoscopy, we did BSO. Along with that, the bilateral pelvic lymphadenectomy. Follow-up, patient is doing well. So endometrial HP mandatory before hysterectomy, particularly in irregular bleeding with increased endometrial thickness and risk cases for corpus cancer syndrome. There are many pressures from the patients that why to do 2 surgeries. You should do the hysterectomy. Bleeding for 3 months, they come for hysterectomy. I say that no, it's a must evaluate. Bleeding for 3 months, there are many unnecessary hysterectomy could be saved for that. No, I think a short period, you give a medical management. If it fails, then you go for a endometrial biopsy, and then if endometrial biopsy is suspicious or it is a hyperplasia not responding to hormones, then you can do the surgery for that. So hysterectomy, remember, in a perimenopausal women, before that, If I come for bleeding, particularly HP study is absolutely mandatory, and postmenopausal women absolutely you should not do the hysterectomy without a HP report for that. That's a message which I can give you. 36 years, multiple myoma uterus, 14 weeks. This is a case a couple of years before. It's not my case, and I was chairing a session in a workshop, surgical workshop in Hyderabad. So 36 years, multiple myoma uterus, 14 weeks, planned for TLH in a workshop. And the surgeon was a general surgeon, not a gynecologist. General surgeon. But believe me, he was excellent. He performed an excellent surgery and absolutely bloodless, not a drop of blood was there, and a clean dissection. And whole audience applauded him. And a standing ovation for the surgeon. Such a fantastic surgery he has done. But the surgeon wanted my comment as a chairperson, unnecessarily poked it, and my comment is very frank. And I opined, doctor, your dissection is fantastic, but decision is dangerous because you have chopped out both normal ovaries in this young patient. Hysterectomy is indicated, 36 years, 14 weeks, multiple myoma, but both the ovaries are normal. Why you have chopped out both the ovaries? That's absolutely wrong decision for that. And therefore, the decision is important what to do. The gynecologist should realize whether the value of oophorectomy should be there or not. So importance of decision making in gynecological surgery is very important. Dissection is a craftsmanship. Anybody used to do that, majority of the people can do it, but brain, the decision is important. Both are important for the skill of surgeon. Therefore, in this episode, these two vital, important characteristics of a surgeon, the decision and dissection, I have made it a special episode for that. 30 years, para 1, A1, presented with one episode of acute pain abdomen on right side, following 10 days overdue. Beta SAG 800, with sonographic evidence of empty endometrial cavity, and right adnexal mixed echogenic small mass of 4 centimeter diameter. There is no fluid, but a mass is there. Pain is relieved on observation following 50 milligram of methotrexate is already given by the concerned gynecologist, but dilating pain persisted for 20 days. After 20 days, repeat scan was being done. Presenting mass, same size was there, 4 centimeter, persisting mass with increased vascularity. One of the color Doppler shows that increased vascularity, then subjected for MRI. MRI revealed arteriovenous malformation. Then from the gynecologist, they have shifted to oncosurgeon. Consulted oncosurgeon, and oncosurgeon has suggested uterine artery embolization followed by radical surgery. Patient confused, depressed, varied decisions from different gynecologists. Now, that's not a decision enigma. This is not it's a very simple case. I analyzed, I examined, repeat beta SAG 600, clinically no abnormality. So diagnosis straightforward, a chronic ectopic, there is no doubt about it. So why unnecessarily you think of malignancy? Why unnecessarily you think of arteriovenous malformation? It is a vascular mass, and automatically the color Doppler will show the vascularity for that. And I did it without anything. Straight away diagnostic and therapeutic lab, right tubal. I find a right tube and ovary buried in the pouch of Douglas with the mass and which is vascular. As soon as I just dissected it, both the tube and ovary came out with ampullary pregnancy with a vascular mass bleeding. And therefore, right salping oophorectomy done, histopathology confirmed tubal gestation for that. What you learn from this? Think of common condition first. Misleading diagnosis by gadgets. Gadgets can mislead you, but you correlate with the gadgets for that. Gadgets can help you as well as misuse. Importance of interpretation of MRI with clinical correlation. I find somehow MRI interpretation is important, and very few people can give a good interpretation of MRI in the present status for that. Apprehension of surgeon as well as patient in such simple cases. If somebody says that yes, you have a arteriovenous malformation, bleeding will be there, and you have a cancer and radical surgery will be there. This is so understanding the basics and methodical treatment is the key to this type of cases. Not only in taking decision, but in dissection and do a surgery also. Well, these are instruments. Then coming to the instruments for dissection, which I have already told, I will show some of the varieties of instruments before you. A speculum is a very good instrument for retraction, for dissection, as particularly the anterior pouch and the posterior pouch. But remember, it's not from the beginning. You just find out a good real space, and then only the enlarging and elongating and lengthening the space, you can use the speculum for that. And this is important. One of the things is a range of instruments I've shown. And the Mayama screw, the traction, counter traction, the seizure, and therefore is a seizure, dissecting seizure. And in the seizure, I've got another with the power, the bipolar. This is a blue thing, and this is a bipolar with a cable is there, you can use it. And these are all red one is again a bipolar, which helps not only in sealing the vessels, but in dissection, particularly in the node. Then these are the bisector. These are the sear, electrosurgical sear, both open as well as these are all open. First is the open short arm, and the other sear is a laparoscopic shear, which I have already demonstrated in the surgery in the electrosurgical devices episode. So this is sear, which is used to the Alan company has used this sear, which is open, and then the other thing is a laparoscopic sear is also there, and these are used as a dissector also. The tip you can see that can mobilized, and not only by applying the electrical current, it can dissect it also the tissues for that. So this is acting as a dissector in laparoscopic surgery and helping us for that. And then the other instruments like the laparoscopic dissector, carved dissector, and this is a very they are the two instruments where this is a forceps with a tooth or a plane, and along with that you can have a carved dissector which traction and counter traction the cyst wall and other thing can be given, or in a dissection, particularly the space, the ureter, the vital structures, you can dissect it with the dissector, and that is important as a laparoscopic procedure. And see that these are the cases where the tip is carved, and this can help in this particularly. This is the dissector with the tip is that, and the Karl Strauss and many other companies have this. These are common instruments in all types of this surgery for that. Then of course the laparoscopic seizure is there, and this one, the thing which a blue one which I show you, which I told that is a myoma separator. You see, this is a myoma separator. See the tip of this, and this is a myoma separator, and there are very important that it is a three end point is there, three big. I think it's not a flat point. It's a 3 points are there, which can really tissues can be held with, and in a very good plane, normal plane, it can separate with that. And of course, these are all harmonic, which acts not only in harmonic as a hemostasis, not only as the cutting, coagulation, as well as dissection. This harmonic can be used for that, and both the open and laparoscopic procedure of harmonic is there for that. And two main important thing in laparoscopy, suction irrigation cannula, and in open your own finger. These are the best and safest, particularly for dissection. So finger, out of all these instruments, I say that the finger is best for open surgery as a dissection for that. Now, then the second part will say the surgical dissection and the different. You see, there are various situations, the common situations where all gynecologists need to have a dissection on a very specialized place. One is in uterovesical space. Now, uterovesical space, if it is an altered anatomy by previous cesarean, which is very common, you have to dissect in a proper plane, otherwise you are damaging the bladder. So this is again a harmonic, open harmonic, and this is the UV space dissection doing an abdominal hysterectomy. You see that this open harmonic, the instruments is a very good way for dissection. But remember, the methodology is that even when you do a vaginal or as well as a abdominal, in a case of previous cesarean, go from lateral to medial. Go from lateral to medial on one side, then another side, then the median. So don't dissect in the medial plane, because the bladder is adherent in the midline. The lateral window, which Professor Siris said, is also applicable for the open as well as for laparoscopic procedure. You see, it's absolutely, you go to the proper cleavage is important. You find out a utrovesical fold, the cervicovesical space, and this is the plane of cleavage. With the, because it's a harmonic, there is no bleeding. You stretch it, the counter traction, traction, counter traction, and subsequently you find a very good space and a confirmed space where the bladder has been dissected. And this with the finger, can you see the finger as well as with the instruments? I can dissect it, and this is the real plane of that. Then you put the speculum. The speculum will again, after this space is raised, then you put a speculum, and then ultimately the whole utrovesical space can be really dissected out, completely free avascular for that. And therefore, this is particularly important in a case where there is a previous cesarean section. You go the sub dissection along with the harmonic or the electrosurgical device with the proper plane, you go in, and that can do that particularly for that. Now, this is a case, again, UV space dissection vaginal route. So, vaginal hysterectomy, when you are doing a vaginal hysterectomy, what you do? They just give an incision about 2 centimeters above the cervical external house, and then this is the area where you find the vesico-cervical ligament. In the middle, you find a vesico. So don't do a blunt dissection here. Don't, many people do a blunt dissection with a gauze and all that. Don't do it here. Sharp dissection, you do it, and you go from the medial, lateral. You go. There is no history of cesarean here, but you go, you cut it. This is a clean cut place where you find that the space of cervico-vaginal ligament, you cut it in the middle, and that's why you go to the good plane for that. And then you enter and go the speculum, introduce it, and then the posterior part again. Posterior part, this vagina is then there. Then after that, the speculum, you pull it from the posterior part. Even if there is this is a case of no, the endometriosis. Later on, we can know that this is a endometriosis after going to these two places, to anterior and posterior space, and the POD, the whole uterus was fused with the rectosigmoid, and therefore the correct plane of cleavage is important for that. And therefore, these instruments help in identifying the current plane, and therefore this dissection is important. Now, this is a case again in laparoscopic. We're doing a TLH in this particular case. You see, there is no history of previous surgery, but a very well dissected anterior utrovesical pouch should be dissected very well. And this is a case in which the same UV space could be dissected by the laparoscopy for that. Laparoscopic dissection. And here, the instrument here is again a harmonic. You can use the harmonic, you can use the bipolar, you can use anything for that. But this is a very important and useful instrument. Harmonic can be used as a dissector, and the utrovesical fold of peritoneum can be easily dissected with that for the again completeness of the procedure of vault, opening the vault after that procedure. So this is a common thing which I want to highlight. There are a number of procedures, number of surgeries. The time doesn't permit me to show everything for that, but only related to the dissection and the method of dissection and the instruments I want to show you in my own series, own surgery. I want to transform this further. Now, this is again a UV space dissection in a case of cervical myoma. You can see the cervical myoma here. Again, the same thing. This is with the sear. That is with this electrosurgical device, the Allen sear I'm using instead of that. And this is acting as a dissector as well as the hemostatic for that. And then we go and cut the myoma and do a myomectomy through that, cutting them. So this is how the dissection is important. I want to show the dissection of the UV space, particularly abdominally, laparoscopically, and vaginally. This is again a case where vaginal surgery in a hysterectomy were planning for 3 previous years. Now this is important. Again, same procedure by SERP dissection, not by a blunt dissection, but the SERP dissection and the cervical and this is the lateral window. You go through this is the dissector, the finger, you introduce it, and lateral window. You introduce it to the lateral window, separate it, and then come to the midline and then the posterior part, you open it, and then automatically everything will be solved. So these are the cases. The space should be important here. The lateral windows of series set. I think this, I salute this person who have revised that. And even with the abdominal, with the laparoscopy, with the vaginal, with the previous cesarean, this is absolutely warranted for the quality of surgery, for prevention of injury for that. Now, then we come to the myomectomy. This is a case where abdominal myomectomy is being done, and is a big, very big about myoma of yes, you can see that there is a big myoma, and here myomectomy has to be done. If you are going for a hysterectomy or other, there is a different issue, but this is a broad ligament myoma. This is a broad ligament myoma, is very dangerous, and dissection in a proper plane has to be given. You see how the finger, I say that is the best and safest instrument for dissection. You can dissect it, and this is a broad ligament myoma, true broad ligament myoma, and false broad ligament myoma. This is a pseudo broad ligament myoma. That means the myoma has originated from the uterus in the lateral part, and therefore this is the joining, and the lateral part, you can see where from the myoma is originating. This is the origin of the myoma from the uterus. Can you see that? And this is a pseudo broad ligament myoma. The myoma, true broad ligament, is originating from the myoma tissue, from the broad ligament tissue for that. So this dissection in a right plane, if there is a vascular thing, you can coagulate. Otherwise, if you go to the perfect plane with the finger, I think whole thing can be very well dissected for that. So these are the cases where you take precaution, because in broad ligament myoma, dissection is very important. There is a risk of injury to the ureter, and therefore you must go to the proper plane of cleavage. And therefore, I feel that the finger is the best dissection, and the proper plane of dissection is important in that particular case for that. And therefore, after completing the procedure, you have gone to that origin of the myoma from the lateral part, then you can do that, remove that myoma completely with a absolute hemostasis for that. So these are the cases where it needs some of the combination of your dissector, and still I believe that finger is the best instrument which can dissect very well. And the uterus is well seen. We are doing it at a young age. We are not doing today hysterectomy, and these are the cases the myomectomy can be done. This is again a case of abdominal myomectomy where the size is about 28 week size uterus, and this is also a case of broad ligament myoma. And you go for that, gradually you remove this myoma. This is a big myoma which the myoma screw can help in bringing out that. And again, the same procedure of the going to the proper cleavage. In myomectomy, the proper cleavage is important. Once you go to the proper cleavage, then it's very easy to do a myomectomy, and the finger can assist you. You can use it with the mop, and like a separating the coconut with the coconut shell, as I have already told. You find out and go to the proper cleavage, and then do the procedure of myomectomy completely with that. And this is how you dissect the big myoma. It can be done very easily if you are going through the proper cleavage for that. And this is the cleavage which I'm demonstrating, and with again a finger, with the assistance of a mop, you just go to the proper cleavage, absolutely bloodless cleavage you find out, and then do a good piece of surgery. And here you see the gauze, the mop as well as my finger is a best, very good dissector to the proper plane of cleavage. So that is important in a case of open myomectomy. This is again a big cervical myoma. You give an incision, and again the key is that you go first of all find out a good space for that. And if you find a good space for that, and go to the proper cleavage and put the myoma screw, and by the traction and counter traction, you can deliver it very good in that particular plane, so that bleeding will be less, and the whole procedure of surgery will be really successful for that. And these are the cases where a myoma screw has been applied here, and then by traction, easily the whole thing can come out. And this traction, counter traction with the scissor and myoma can have a dissection completely. It's a big myoma which is arising from the cervix, and this can be done very easily contemplated with this procedure, and that is the key of the plane of dissection. And this plane of dissection with this dissector, with the counter traction and attraction, I think that whole procedure can be over with that. And believe me, these are the cases where it needs some of the technique which everybody can do that, and see a large myoma which is gone inside the uterus also, it is come out for that. And that is possible if you are going to the proper cleavage with that, and that's completed because of that. Is again a laparoscopic myomectomy. Laparoscopic myomectomy, I have already shown you the procedure of myomectomy, but the process, well, the two things, the dissection part, I will just show you how the dissection has been done. And with the myomas, with the harmonic scalpel, the incision is being given and the space is identified. But the space is again very clear if you dissect it by the harmonic, because as and when required, the bleeding is there, you can coagulate. So this acts as hemostatic as well as cutting and as well as dissector. This is acting as a dissector, helping as a dissector. So once you find a proper cleavage, now the proper cleavage has been seen, and then either with the harmonic you can do it, or better, don't use this costly equipment for the separation for that. That's why I always use the myoma screw, a myoma separator. This is a myoma separator. So after the finding out a proper plane of cleavage, this myoma separator is there, which is very important to separate this, and the proper plane, this myoma separator is separating it, and then you can do the job. And this is a procedure of dissection. The only key is that you have to identify which is the proper cleavage and the capsule. That is called a capsule. And if you go through that, I think the bleeding will be less, and the whole myoma can be enucleated with really within minutes, and with less blood loss for that. And this is the role of myoma separator, which I have told that if this can be used, and you can go all around to separate to a particular plane, and then you can get it. The whole myoma can be delivered in a perfect plane for that. And that completes the procedure of a laparoscopic myomectomy. Then after that, this is important because the bleeding, otherwise the bleeding will be more if you're not going to proper cleavage for that. So this is a laparoscopic myomectomy procedure. Big myoma can be done. And this is another laparoscopic myomectomy of fundal myoma, anterior fundal myoma, which is again the same procedure. We can do that after vasopressin. So this is a procedure which facilitates the procedure by giving a vasopressin infusion. And remember, the vasopressin is a really safe procedure. Don't be panicky about that. But remind the anesthetist before injecting the vasopressin, there could be bradycardia, and a simple measure of putting the atropine can solve the purpose for that. So again the same philosophy, that the space identification of the proper plane of cleavage or a capsule is important. So therefore, I always say overcut, don't undercut. If you overcut, then you can find which is the space. Otherwise, everything will look like a space. So I always advise this is overcut, and then I can find that this is the proper cleavage. I've gone beyond this. So this is important in a myomectomy. May it be open, may it be laparoscopy. The same philosophy is maintained, that you overcut. And this is the myoma separator which is being used to separate it, and the whole procedure can be completed with ease. And big myoma can be delivered with that, and then you can go for suturing. But the dissection part is absolutely important. If you're not going with a proper dissection, then the bleeding will be more. I think it's a messy surgery, and postoperative problem will be there. Even if you can suture is much more. But if it is a dry, if the blood loss is less, and it's not a messy, you can suture. And suture is also suture much more methodically and much more easily and safely. And therefore, there won't be any postoperative complications for that. So how the myoma separator can help in this particular case, you just imagine. And this is a dissector, help in dissection for that. So everything depends then the skill of the surgeon, how to dissect that particular plane. with which facilitates that. There could be many other different varieties. The surgeons may vary according to the instruments also, but the main thing is that the dissection process should be absolutely in the perfect plane, in the right cleavage for that, so that you can do a good piece of surgery for that. And the myoma screw, it has got three prongs, and it's not flat because can you see that the tissue which is there, small tissue, can be really grabbed and retracted much better for that. And it's a very cheap instrument, and don't use the costed instrument of the other laparoscopic hand instruments, which can be liable to be damaged after the use for that. So this is the method which you go very slowly all around, and then you find that yes, these are some of the tags which is there in a proper plane. This is the plane which is there, which you separate it with that plane, with that tissues which is just gripping that, and after that procedure is over, then you go for suturing and other things for that. This is again a typical case of this has been done earlier. A hysterectomy has been done, and the patient presented on subsequently 1 year after that. Patient came with complaints of pain left iliac fossa. On sonography, we find that there is a hypoechoic lesion, and what is the lesion we couldn't. But when we put a scoop, we find that there is a in the anterior to the left round ligament. That is the thing, and therefore this is what I told about the hydrodissection. You push a normal saline, simple normal saline without that, so that the plane can be easily obtained with that, and then you can go with that plane. And this is the plane which you find it, and then we can find that this is nothing but a myoma which is there completely before the myomectomy, before the surgery. It could be there, maybe that, or after the surgery it could be developed, but it is completely separate from the uterus. And this is a case where again the myoma separator is being used. I've used the myoma separator, and with that plane, with the traction and counter traction with the myoma screw, or with the, you can use the other these carved I think the the valsalum, you can use that laparoscopic valsalum, you can use it with that, but giving a traction and counter traction with that, the whole myoma can be delivered. So this is how the dissection is completed, and these instruments can facilitates our surgical dissection for that. Now this is again a vaginal hysterectomy. While doing this is multiple myoma uterus of about 24 week size, and I was doing this, the previous normal delivery, 2 normal delivery, and this myoma uterus, how you can do vaginal delivery is possible, because the myoma, you can use the myoma, giving a traction, giving a location of the myoma by giving a bisection. We find that the myoma is located on that particular thing. Once you identify that the myoma, this is the myoma, then you find out and apply the myoma screw in that particular plane, and give a counter traction. The tumor is high up, but even with that, with the traction and counter traction, it has come out with that. So main key again, I will say, whatever you do it, either a laparoscopic or a vaginal or something like that, but this is again a myoma, which again the good space is important. If you are going to the proper space, and this traction and counter traction by these instruments will deliver the myoma completely. And see, the one myoma is delivered, and after that, this is again a right side broad ligament myoma. Once you find out the place, proper plane of cleavage, with this simple traction and counter traction in the perfect plane, it will come out with absolute hemostasis, no bleeding will be there. So these are all examples of dissection, the methodology in which you do it for that. This is a case again, a dormant cyst ovary of about 8 centimeter diameter, left ovary. So dormant cystectomy. Dormant cyst, I think very important that the dormant cyst enucleates much better. The plane of cleavage is much better in dormant, but the chance of the rupture is there But even if it's rupture, also don't worry about it. You can do a good peritoneal toileting for that. But one point is that if you go to the proper cleavage, I think it can be enucleated very, very easily for that. And this is how you do by traction, counter traction, and finding out a good space. Main thing is that you have to find out a good space, a normal space, which is right cleavage for that. And this traction and counter traction will give a proper identification of that space, and total enucleation can be easily this is um, facilitated by these instruments for that. So number one, you have to identify the going through the proper cleavage for that, and then with the two instruments you can just dissect it in the right plane. This is a dissector, laparoscopic dissector, which I'm using it. Just remembering that these are the cases where the whole of the dormant cyst can be delivered it very, very easily with that, and without rupture also. So this is a dissector. This is the dissecting plane of the cyst wall and the healthy ovarian tissue, and therefore this is very easy. It's not a very difficult surgery for that also. But only thing is that I just want to emphasize the role of dissection in that particular surgery, and that if it is there, then absolutely the go to the proper cleavage with the proper instrument, whole thing can be out, and you can take out with that without spill also. This is a case I'm going to the proper cleavage so that it doesn't spill. But even if there is a spill also, don't worry about dormant. It can be very well, the peritoneal lavage can be done. But this is a procedure how the dissectors can help in the proper dissection, emphasizing the procedure of dissection. I showed this video to you, and this dormant cyst is out, and now you can deliver it with the lap sack or something like that, and intact you can come out for that lap sack. So these are the procedure where a dormant cyst of about 8-10 centimeter can be delivered. This is again a big ovarian cyst of about 26 week size. The ovarian cyst, it is a serous cyst, Doppler flow normal, and 26 weeks. And she's a case of infertility, a young 26 years, 4 years infertility, and therefore these paravariant cysts we just enucleate it with that, and you see the big cyst can be enucleated with the traction, counter traction in a completely um, good plane of cleavage. So these are all big cysts. You can puncture it, you can reduce it, the fluid, and then after that you can do with the two instruments, either a dissector and with the tooth forceps, you grasp it. This is how the whole of the fluid has been done, and proper cleavage is essential. You hold with that, and then you dissect to the proper. Initially, you have to identify which is the point. That's important. Once you got the point and the cleavage, then things are very easy. You can go through the proper plane of cleavage, and whole thing can be enucleated. A big cyst can be enucleated. That is not a problem. So this shear can help in absolutely in coagulation with that, and whole procedure is completed very, very skillfully, and this is how the whole of these ovarian cysts can be delivered, and the small twigs which is bleeding can be coagulated with the whole thing. The can be coagulated, the rest of the part can be coagulated with that, and that completes the procedure of ovarian cystectomy for that. So it needs a dissection, and this dissection needs some instruments, and basically these two instruments are necessary. One is to have a traction and a counter traction. So with the correct plane, it will come out, and if there is a little bleeding, you can have, and absolutely the bleeding is not much as you go to the proper cleavage, and the bleeding is not much, and big cyst can be enucleated completely by laparoscopy. So laparoscopic procedure can be done with this ovarian cyst, and for that, these are the specialized retractor, these dissectors, which is essential. Along with that, the electrosurgical device can help us for that. So whole thing cyst can be dissected out, and then it can be delivered uh, by it can be brought out by some other means, either by morcellation, or you can go with the second coat with that. Now, this is a chocolate cyst. Again, chocolate cyst is little difficult because there are adhesions with that, and I have demonstrated few of my videos during the endometric session. And here, a big chocolate cyst on this particular aspect, bilateral chocolate cyst with the grade 4 endometriosis. You just collapse it, and this is how. This is what I told about the suction irrigation cannula. It's a very good dissector which can dissect the whole of the ovary, tube, adhesions, and all that. It can act as a dissector, and therefore this is a very fond of this particular instrument, suction irrigation cannula. And where it's a blunt dissection, but it can go to the proper, I think, plane with the least damage to the adjacent structures, the lateral pelvic wall for that. So this is how I'm going to show the demonstration of how the whole of the ovary, which is fixed to the lateral pelvic the ovarian fossa, and this is the ovarian fossa, and as well as the posterior surface of the uterus and rectosigmoid. So with that, how with the relatively less minimal injury to other things, with the proper cleavage, this can be delivered, this can be nucleated and dissected. That is the purpose for which I have shown this, and many people have a different methodology for that also. I don't deny that everything is good, but the dissection and proper claim is there. And of course, the same instruments, you can just separate the POD, and the rectosigmoid can be really clean by that. You can see the rectosigmoid which is separate. This part, the right side, some of these ovarian tissue is there which is being coagulated. Then the cyst wall. Now you can see the cyst wall. Identification of the cyst wall is done like this. So once you find that this is a cyst wall, the initial part is important. Once you catch hold of this cyst wall, then the traction and counter traction by the two instruments is really unique for that, and you can do this dissection very well for that. First of all, you separate it with the suction irrigation cannula. Then with that, if you're going to the proper place, how beautifully it is being released and separated, and the dissection is complete. So the art of dissection you should know, and then everything can be good for that. Thank you. Now, this is another case, unilateral adnexectomy. This is a fertility promoting surgery. When I find that the uterus is normal and there is a big left TO mass, tube ovarian mass with endometric cyst, and the right side ovary is normal. So the dissection, I think there is all adhesions around it, the gut, the omentum, and everything is adherent around it. And this is a case where the right side ovarian tube is normal, absolutely. So this is an example of unilateral disease, unilateral endometriosis with extensive adhesions. You just dissect it, and these are all jellies which is found, dissected from the vital structures, particularly the gut, and then do a salping oophorectomy. That's much better for that. So this is a dissection in which the total TO mass is being released from the omentum and adjacent vital structures with the bed of the ovary and the uterus. It can be released. Then collapse the mass with the puncture over the mass, prominent mass. Then again, identify that these are there is no vital structures which is there. These are some of the intestines which is adherent to that, and you just separate it with that, and then you can do a good job. So the dissection is important. Otherwise, you separate it from the gut. This is the gut which is adherent to that, and this is the TO mass. After separation with this, again the suction irrigation cannula, which is my favorite, and then you can go for the salping oophorectomy. It's not a very, so this, unless you do a dissection and unless the tubes and ovaries are just released and restored to normal antral position and dissected from the vital structures, the things cannot be done there. And after that, you can do a salping oophorectomy. So this is a fertility promoting surgery where you don't do a cystectomy, you do a fertility promoting surgery in a case where the other size ovary is normal. We do a lot of hernia repair also. I personally do a lot of hernia repair if there is a incisional hernia, I don't say that the surgeons will do it, and surgeons will say always that yes, yeah, the gynecologist create hernia for us. That's a very humiliating thing, and therefore I don't call the surgeon. And do they, if there is a, this is a case of incisional hernia where the trick is that the dissection and layer separation is important. You must be able to do the separation of the layer and find out the weakest point, which is the weak part and hernial sac, and that's why it is important for dissection. So hernial sac you identify. Otherwise, you just do it and put a mesh. Doesn't. I don't. I'm not in favor of mesh always when there is a large defect. I find. Otherwise, you identify. You just dissect it. This is a dissection by seizure. Can you see that dissection by seizure? And all around is the peritoneum which is dissected. Then the rectus sheath will be dissected, and after that, the weak portion I will excise it and then repair it. But the dissection part is more important in hernia rather than the repair. So don't think that we have got a mesh we can put it, and don't think in that way. But this is how you dissect it all around, and therefore the things becomes very easy for that. And the dissection here is mainly by the seizure, which and with or without the hemostatic part and all that. Now the whole peritoneum, the sac is completely dissected. Then we'll dissect the this is the dissection of the rectus sheath, healthy rectus sheath which is there, and then only we can oppose it and repair it by layer method. And therefore this hernia needs a very good, you see that dissection, how the seizure is helping me in dissection for that. And unless I find a healthy rectus sheath, I can't have a repair, close to anatomical repair for that. And therefore the importance of dissection in hernia is important. This is again a scar endometriosis, which is our subject. It needs a wide area of dissection, and a healthy area should be there. Otherwise, if I leave a small area with endometric lesion, the recurrence will be there. And therefore, find out all around which is the healthy area, and the rectus sheath, and just this electrosurgical device or monopolar needle along with the seizure and our finger can help in dissection for that. So this is how a combination of the hand or finger as well as the unipolar electrode and the seizure can help, can serve the purpose for that. This will help that the where is the limit of this endometriotic scar endometric lesion, and therefore avoid from the scar endometric lesion. You find out the healthy area of the rectus sheath, and from there you totally remove it. And majority of the cases it is overlies the muscle. You can excise the rectus sheath on that particular area and repair it for that. This is a large endometrial scar endometriosis, and for that you can see the dissection part, how the rectus sheath is visible all around, and that is very important to have a prevention of the recurrence as well as completing the procedure and doing the procedure for that. And this is important. Unless we dissect it all around the fatty tissues, we cannot approach, we cannot see the rectus sheath. Now this is, you can see the rectus sheath, everybody can see the rectus sheath now. This is all around the rectus sheath is shown, and an incision is given on the rectus sheath, and all around it is there. Most probably it is sitting over the muscle, and therefore the bleeding feeding vessels are there here, and you just enucleate that completely from the above the muscle, and therefore the wide excision and dissection is absolutely essential in this particular case. So the same as hernia and all that, we give a repair for that, and this is the rectus sheath. The only thing is that we don't allow a remnant of this endometriotic lesion. So if the remnant of endometriotic lesion is left behind, again the recurrence will be there, and therefore a meticulous surgical technique with the good dissection is absolutely essential for that. Now it's removed. This is a solid ovarian tumor which is done abdominally. It could be done, it could have been done also vaginally, but I think the patient preference is for abdominal, and therefore I did evaluation of the solid ovarian tumor preoperatively. The um, these all these biochemical markers. I've done that along with the color Doppler. The dissectability is very good. It goes to the same place and all that. It's just like a separation of a myoma, which you have shown it. The finger is enough for that, and therefore this is a finger dissection is completing the procedure in the whole area of the solid ovarian tumor. This comes as report came out to be a these fibroma of the ovary, but the dissection is there is a small amount of feeding vessels which I wanted to coagulate with that, and then the whole rest of the procedure, whole of the solid myoma, solid ovarian tumor, it is enucleated by the finger, and this is a dissector. The finger has helped me in proper plane of identification for that, and now the whole thing is completed. Now this is complete. Now this is again to show you a radical procedure, and a Verdin procedure is the posterior part. How you dissected the posterior part. This is important. The posterior. We have already dissected the ureter and the other lateral pelvic wall, and then this is the posterior part to designate that the posterior dissection. And here it's very important. The fat will give a guide for that. And always I say that the fat doesn't belong to the gynecologist. Fat belongs to either the anteriorly the ureter or the posteriorly, mainly the posteriorly the rectosigmoid. So that is a part where we dissect it, and this is a harmonic which helps in our dissection for that. And this is a case where Verdin's radical operation has been done, and this is a space where you can go straight away low down as possible in that proper plane of cleavage, the fossa of Dinenweiler, and everything can be dissected with that. So this is how the posterior dissection is being done. Posterior dissection has been done. Okay. And same thing, the anterior dissection, I have showed the UV space for that. This is how the proper cleavage, you go as low down as possible. And the thing which we are doing by finger, by the hand also, we can do that dissection. And this is the procedure where you do. This is the exact layer. The previous layer, we have gone to the wrong layer, and then we corrected it and find out that this is the layer which is the real layer for that. And this is the lateral space where you find the Okawashi space. This is which I was telling about the space. When you put the gas, automatically everything is visible for that. And you can remember, just to show that what are the pelvic spaces in radical surgery. This is very demonstrable, and with the help of harmonic, we have gone just up to the we see the muscle also deep into that, gone into that. And when the gas also favors that, the pneumoperitoneum favors this particular entry of that, so that the dissection, we find the fat, that is the limit of the surgery for that. So this is the pelvic space, the pararectal, as well as the space of Okabayashi. We just do it, and that is necessary for the final procedure, and that is important for that. And absolutely, you can just to demonstrate that how this space is avascular. That is why I just demonstrated and dissected the space for that. And this is the very important space where the muscle is seen for that. And this is the last stage of the Verdin's surgery, where everything has been dissected, and then the gland dissection. This is the gland dissection is not very difficult procedure, and you can see the vessels, the extrailiac vessels, the extrailiac vein and artery, and over it the extrailiac chain of vessels, chain of glands can be dissected. And this for dissection again, and we can use the harmonic, we can use the electrosurgical equipment, and go to the proper cleavage, so that the gland can be very well dissected with that. The obturator, the interiliac, and again we can see the nerve, the obturator nerve for that, and that is the limit. Don't go beyond that. And you can see the whole gland in a chain that can be really removed with this. So gland dissection can be very well done by a laparoscopic procedure for that. So this is again in contrast to laparoscopy, the pelvic nodal dissection by open. So open dissection, I will show you. This is a closure of the vault which is there, and then we're going for the gland dissection after that. So the pelvic node dissection is also can be done by Caesar, can be done by with or without the assistance of the electrosurgical device. Now see the whole of the pelvic structures, how it is skeletonized, and uterus is out. Now the gland dissection procedure starts. And here the gland dissection, you see the technique of dissection, that Caesar, or this is a particularly the bipolar forceps, which helps in the dissection for that. And this, my friend Sushil Giri is very favorite of this particular instrument, and he always favors. Earlier Caesar was doing it, but now I think I've seen that he's doing more with the bipolar. And these are the vessels above which, and this is another method in which I've shown that how with the Caesar dissection, whole chain of glands can be dissected starting from the lower part till the bifurcation gland. And this is how the whole gland can be dissected on both sides and sent for HP study for that. But remember, en bloc dissection has a merit of it, and then you go for interiliac and obturator is the next branch, and this is the externiliac. The other chain is the externiliac, and see the method in which the gland can be dissected. This our bipolar forceps is helping as a dissector for that. So this is one aspect for that. And then the whole gland pelvic node can be dissected very well with that technique, and either Caesar or with the bipolar forceps, you can use that. The advantage of bipolar forceps is that there is a bleeding. This is the internal, I think, the interiliac and the obturator. The obturator nerve is visible now, so it is separated, the obturator nerve, and here the dissection is combined with this Caesar as well as the bipolar forceps, dissect bipolar forceps, and the whole chain of glands can be dissected with that. This is on the left side. We have demonstrated that how, but beyond that, below that, there is no gland is there. But be very gentle that interiliac vein is there, and there is a chance of injury to the interiliac vein. But if you are cautious in that dissection, I think this is very rewarding for that. And therefore, the dissection is an important part. The skill of dissection one should acquire, and which plane safety limits of the dissection you should know, and what are the proximity of the vital structures, damage to the vessels, damage to the ureter, damage to the bowel. All these are important procedures for that. And therefore, after that procedure, you see that whole thing can be skeletonized, and you can see not only the whole lateral wall of the pelvis, how it's clean, the obturator nerve and external artery, interiliac artery, external artery and external vein, both can be seen for that. And you sent it for HP study for that. So then this is the other side. The left side is completed. The right side, then we go for the right side. Up to the bifurcation, you can complete the procedure for that. The finger can aid in palpation whether the left remnant is there or not. So this left side is completed because of this. Then we go for the other side. The other side, you can see how from the vessel wall, anterior surface, it is just separated and dissected by the Caesar. The curved round Caesar, curved Caesar with half open, I think this is the best way to dissect it. And if there is a bleeding, you can use the bipolar for that. And at the level of the, say for example, at the point where the origin is there, you can use the bipolar forces. So this is all the extrailiac chain which has been enucleated, and then we can go for see the large node which is there, the interiliac node, and this interiliac node seems to be very large. And remember, this is separated from that, below above. From below above, the dissection is carried out, and that is important for that. And once you find out that this is close to the vessels, very, very carefully you should do a pelvic lymphadenectomy. And this is the charm of the dissection which matters. And with or without the application of the cautery, the electrosurgical device, or simple with the seizure, you can do that. In vital, wherever you find that there is a bleeding, you can use the bipolar forceps. Otherwise, with the seizures, I've shown you the seizure with the cautery, and that also you can use it. And this is an example of pelvic nodal dissection by the open method of radical Verdim procedure for that. And this is very, very important of procedure of dissection. The importance of dissection one should realize while doing this pelvic nodal dissection. Thank you very much, ladies and gentlemen, my viewers. And I have started with something, a concept on a decision and dissection, and then the decision where not to do a surgery and where to do a surgery, which modality of surgery you adopt, and with special reference to the dissection, the different techniques, different steps of gynecological surgery, and tips and tricks, and some of the clinical dilemmas and situations which I have enumerated. Thank you very much again for giving me this opportunity on the first anniversary of our e-Gurukul program by Juventus. Thank you very much.
Thank you very much, sir. Thank you very much. And
Sanjay, thank you. Yes, Sanjay, thank you.
Thank you. On the occasion of Teachers' Day, I want to quote the famous writer, the William Arthur Ward. He says, "Some teacher tells, the good teacher explains, while the great teacher demonstrates and inspires the young minds." Yeah. So you are the great teacher. You have shared your life lessons with us. Thank you very much, sir. Thank you very much on this teacher.
Sanjay, as a teacher, I felt that A to Z of gynecology, I cannot teach my students. If I will prove myself to be a good teacher if I can inspire, if I can motivate the people, motivate my students in the interest, create an interest in the subject of gynecology. That is my first thing. If I could be able to create interest in the subject in gynecology, then they can excel me and excel any other great teachers for that. You are right.
Thank you, sir. So there are so many congratulatory and gratitude messages for on the occasion of this Teachers' Day. So I will start. So I will start with the questions. Dr. Aruna from Kolkata, West Bengal. She wants to know, when is the live surgery going to be screened?
When is the
live surgery?
Yeah.
Going to be screened.
Yeah. So, yeah, as soon as because of the corona, we are not doing it. Otherwise, we are absolutely, I'm in plan for relaying the live surgery to everybody. And therefore, I'm very fond of live surgical workshops all over the country. And I have demonstrated few, and many, not only me, many of my colleagues, and particularly on the Foxy Forum, on the different committees, I have done that, and I wish to do that.
Okay, sir. So second question is from Dr. Neeta Bansal, Dehradun, Uttaranchal. And she is asking, how will we do interiliac ligation in case of PPH?
So this is a different question where complications are one aspect and obstetric complications is another aspect. Well, if you ask me personally, PPH, 99.9% are created by us. With all humility, I can say, with I think that is my personal experience also. So prevention is very important. Number one, why I highlight this? Interiliac ligation is not a wonder surgery. Remember this. Interiliac ligation is not at all the sole life-saving surgery for that. I have seen people doing stepwise devascularization, and in a multiparous individual, just to demonstrate stepwise devascularization, internalization, and at last they do a hysterectomy when the patient is no more. I think that is very, very bad. But interiliac ligation, I believe that it has got a definitely place unilateral internal ligation in a case of the rupture uterus or a broad ligament hematoma, unilateral. That is excellent. And internal iliac ligation is not at all a difficult job. And particularly if you dissect it uh, just in the lateral plane, you dissect it and dissect the ureter little, not more than that. And you can get the course of the external iliac artery. Then after that, follow the common iliac artery, then follow the common iliac artery where there is diverging to the external iliac, and then internal iliac. Just a 2-3 centimeter dissection down, you can find the internal iliac, and you can just do a ligation for that. It's not very difficult procedure, but the purpose for which it has been done, that must be very clear. And the decision for internal ligation right is important. The decision is important of internal ligation, where you do it. That is important.
Yes, sir. Correct, sir. So the third question is from Dr. Simi Mahesh from Ranchi, Jharkhand. She is asking about the complications of hysterectomy.
Complications of hysterectomy, I had done 2 episodes on hysterectomy and complications of surgery. I think the complications of hysterectomy varies as far as the route of delivery, route of hysterectomy. The complications of lap hysterectomy is something different. Complications of vaginal hysterectomy is something different. Complications of administrative is something. But the commonest complications is hemorrhage. Second most complications is injury to the organs like the bladder, ureter, or the rectosigmoid. And the other complications like deep venous thrombosis, infection, all these are other complications for that.
Correct, sir. So the next question is from Dr. Gangadhar Munda from Cuttack, Orissa. And doctor is asking about the role of salpingectomy in hysterectomy.
Role of?
Salpingectomy.
Yeah. The concept of salpingectomy came when the concept of the ideas of the ovarian cancer and the papillary serous cystadenocarcinoma, the aggressive variety is mainly 70 to 80% comes from the tube, origin from the tube. That concept gave rise to everybody. That from that time onwards, for the last, say, couple of years, say more than 6 years, see, for example, 2015 onwards, all the gynecologists almost, and we also favor doing a salpingectomy. Ovary has to be preserved. You keep the ovaries, but remove the tube so that there is at least you can prevent the development of post-hysterectomy neoplasia of the ovary, particularly the aggressive lesions.
Sir, there is a similar question from Dr. Gangadhar Munda also, saying what is the role of salpingectomy in hysterectomy?
Therefore, I say that salpingectomy and hysterectomy, now the concept is related to the development of residual ovarian carcinoma, the carcinoma developing from the residual ovary. And that is the purpose when the aggressive lesion 70 to 80% originates from the tube. That was the concept for which we do the salpingectomy to prevent the occurrence of aggressive lesions of the ovarian tumor.
Correct. Right. Sir,
Yes,
there is
sir.
a question from Dr. Sudhir Gupta from Alvar. He's asking, what about the treatment guideline for pelvic endometriosis involving rectum and which is looking inoperable on opening the abdomen because no proper plane of dissection and more possibilities of rectal injury.
I think I have clearly shown in my episode on endometriosis. We have done 3 hours discussion on endometriosis where I've shown the deep infiltrative endometriosis and involving the rectum. I think it's surgically not possible. There are 2 things: involvement of the rectum. If there are complete rectal involvement, you have to do take help of colorectal surgeon, and in that case, the total colostomy and resection has to be done. And cases where it is not completely involved the rectosigmoid, you can just save the endometric lesion from the rectosigmoid and can do the surgery. But it's a very difficult surgery. Believe me, only skilled surgeon can do it for that. So therefore, in those cases, if the medical management is able to give some relief, particularly pain relief, I think it should be the first resort for that.
Right. Yes, Sanjay. Okay,
Yes,
Dr.
sir.
Kedar is.
Sir, the from Jyoti Wadhwa, Dr. Jyoti Wadhwa. She wants to ask how to
Your,
stabilize.
Kedar,
your sound is
just,
not
I'm
clear.
not audible. Be loud.
Sound.
Yes, sir. The next question is from Dr. Jyoti Wadhwa.
Yeah.
She would like to ask how to stabilize mobile tense cyst.
Mobile?
Tense.
How to?
Stabilize
How to
mobile.
stabilize the mobile tense cyst.
That is very important, particularly while doing a laparoscopic surgery. That is very difficult because the open surgery we cannot we can handle it by the assistant holds it, or you can hold it. There is not a problem. But if it is a mobile tense, even with the laparoscopy also, you don't want to fix it. Why at all want to fix it? You just find out that you give an incision. You want to give an incision, or in that particular shape is the large cyst, you better with the trocar introduce it to the cyst, and then evacuate the contents. The fluid will come out, and then after that the whole thing will be collapsed, and then you can hold it. There is not a problem for that. Because it's a tense cyst, you cannot hold it with any instruments, the layer and all that. That is the only problem with that. So therefore, this methodology by including that is important. And for that, we must be very sure that it is not a malignant cyst. Your preoperative, therefore, assessment of malignancy has to be done in all cases. Otherwise, laparoscopy is to be contraindicated for that. And therefore, you puncture it, collapse it, and then you can easily get it. There is no question of mobility then.
Correct, sir.
There is a question from Dr. Purnima Nepram from Manipur. She's asking again for cystectomy only, that after cystectomy in case of dermoid cyst, in how many percentage of cases will there be any recurrent cyst from leftover normal ovarian tissue, as as per your experience?
See, when this happens, when there is a undiagnosed multiloculated dermoid cyst on a particular ovary. Otherwise, if there is a single dermoid cyst, this doesn't happen. Because during the procedure of the cystectomy, you are sure that whether you have kept part of the cyst or remove whole. If you have kept part of the cyst, it will go to recur. And if you have completely removed it and then recurrence is there, most probably it is an unrecognized second small loculi of dermoid cyst, which is not being diagnosed during the time of surgery for that. And therefore, after doing a cystectomy, you always inspect the bed and the healthy ovarian tissue which is left behind for evidence of that. Second most important, which I will say, that ovarian cyst, dermoid cyst, in comparison to the other cyst, the bilaterality is little, incidence is more. And therefore, you have to inspect the other ovaries to find out whether there is evidence of dermoid cyst or not. And therefore, preoperative evaluation by now high resolution sonography will guide you. And when there is a dermoid cyst, I always ask the sonologist, look at the other ovary to find out that, and look at the same ovaries, whether there is a single dermoid cyst or a multiple loculi which is there for that. That could avoid situations for that.
Yes, Sanjay.
Yes. So the next question is from Nirijog Chandra Prabha, Visakhapatnam, Andhra Pradesh, and she want to know the easiest way to remove the mass or salpingo-oophorectomy when we do Ward-Mayer's hysterectomy or NDVH.
Well, Ward-Mayer's hysterectomy, particularly an NDVH, why you remove the ovary? That's the first question. Whether the decision of removal of the ovary is there or not. Number one, if it is a pathological, if there is adhesions, if there is a teomas, if there is an endometriosis, you must remove it. Otherwise, healthy ovary, where there is a strong family history of malignancy, you remove it, or a BRCA1 or 2 positive, you remove it. Otherwise, healthy ovary, remove the tube, don't remove the ovary. Now, the steps of removal of this adnexa is the same. How you remove it by abdominal method, where the same procedure you do it. How you remove it by abdominal method? You just cut it, the round ligament first. cut the round ligament first, then insinuate your finger, go to the infundibulum pelvic, and then remove the ovarian tube. That's very simple. Same procedure we adopted vaginally also. In vaginal also, after the pedicle, the upper pedicle, you just catch hold of the round ligament first. So the catch hold of the round ligament, if you catch hold of the round ligament first, either suture it or with vessel sealer, you go for that. Then after that, you cut it, and then you can go the infundibulum pelvic and put a clamp, or with the vessel sealer you can apply it. The only thing in the vaginal is that because it's at a higher level and there is a chance of bowel coming on that, you have to repose the bowel through a piece of gauze so that you don't think, particularly when you're using the vessel sealer. When a current is there, you must be very, very sure that the infundibulum pelvic, there is no bowel adherent to that. And that is very important. You recede it, you pack a pack over it and catch hold of the round ligament first. Then automatically, if you cut it, the whole infundibulum pelvic is done. It's very easy for that.
Right, sir. So there is another question from Dr. Vijay Lakshmi Shishadri from Chennai. She's asking, like, what's your opinion on ureteric stenting in some surgeries on huge fibroids and endometriosis?
Pardon?
See, what's your opinion on ureteric stenting
Acha.
in some of the surgeries with the huge fibroids or endometriosis?
I know Vijayalakshmi is a very knowledgeable gynecologist and very regular in that. I congratulate you today. Well, this is a very important thing. Some of the cases of huge fibroid and endometriosis, we find some ureteric involvement. There, we diagnose it pre-operatively. Some of the cases, the sonologists say that there is a hydroureter or hydronephrosis on that particular area, and the pain is there. Normally, if it is of endometriotic origin and just removal of the endometriotic lesion or fibroid doesn't suffice. If it is only fibroid is there, by pressure effect, the ureter is involved. Then doing a myomectomy or hysterectomy, the ureter will be reverting back to normal. But if it is associated endometriosis, it could be endometric lesion which is acting as a stricture on that particular part of the ureter, so that in that particular case, ureteric dissection is important. If you dissect the ureter, find out the periureteric endometric lesion, you just excise the periureteric lesion, and then subsequently you can do a good job for that. In couple of cases, I find while doing a dissection on that, the ureter is at times very, very thin on that particular. There is a stricture of such an amount that there is a thin ureter. In those cases, in addition to the dissection, we put a stent along with that and finish the procedure for that.
So you make it so simple. It's great.
What is the I don't know whether it's the right or wrong, but this is the way I do it.
Sir, with this, at this moment, we finish with the questions, but there are so many people who are reciprocating for the Teachers' Day, and they are thanking you for your, all the contributions, and all the wishes are there for you, sir.
Thank you, Diwan. Your wish, my gynecologist wish has stimulated me to continue for 1 year. I say I was talking to them, we will end it with that anniversary of 1 year completion and all that, and or we'll continue, then we'll decide after discussing.
Right, sir. Right, sir. Thank you so much, sir. Thank you very much for your presence.
Thank you very much. Thank you very much.
Thank you.
Thank you.